Uh, Good evening, everyone. I am Nikhil Pise from Solaris Division of Sun Pharma. Welcome you all for this evening webinar. Thank you for joining us. Today, Dr. Sitesh Roy is with us, who is going to speak on the topic of immunity to COVID-19, evolving concepts and future directions. Dr. Sitesh Roy is a US board certified allergist, immunologist, and asthma specialist. He is founder director of Dr. of Roy Health Solution Multispecialty Clinic in Bandra, Mumbai. He trained and practiced in the US for 14 years before returning to Mumbai in 2011. He is also TEDx speaker and author of many articles. Dr. Roy is pioneer in the field of allergy, immunology for children and adults, with more than 20 years of experience. With this brief introduction, I will hand over the session to Dr. Roy.
A very good evening to all our attendees. Thank you very much, Nikhil, for that introduction. Thanks to Sun Pharma Solaris Division for organizing this program on immunity to COVID-19, evolving concepts and future directions. We are all aware that the entire infection that has taken the world and especially India in its hold and has put a third of this world under lockdown is clearly something that we are learning a lot about with each passing day. So we're going to discuss the problem, the spread, the impact and response so far, what the immunologic aspects are of this disease, because ultimately you have to realize it's not the virus that we have to be scared of. It has to be how good is our immune system really to ward it off in a smart and effective way that really matters. The current therapies and the future options, and then staying safe and boosting our immunity, all of which are so important in these times. So coronavirus is actually a very old foe, you can say, of humans, having jumped from bats and a variety of different animals such as civet cats, camels, and other animals, including pangolins. This infection with what we call the common coronaviruses, which are listed in the first line, HKU1, NL63, 229E, and OC43, actually cause up to 20% of the colds, the common colds that we see every year in our practices around the rainy season, around winter, around change of seasons. So the viruses are very common and have been in circulation for more than 50 years. SARS-CoV, which was the original SARS virus, came in 2002, 2003. MERS came in 2011, 12. And now the novel coronavirus, which got labeled as SARS-CoV-2, came in 2019. It is a beta coronavirus, is this 25 times bigger than the SARS virus. And the most difficult part about this virus compared to SARS and MERS is that it has an immense amount of asymptomatic or pre-symptomatic transmission. And it has an immense amount of stability outside the human body, both of which were not features of SARS and MERS that we saw earlier. We are aware that it enters through the angiotensin converting enzyme to receptors, the ACE2 receptors. And while we believed that these were only primarily in the respiratory tract, we have to realize that ACE receptors are present in the esophagus, the upper stratified epithelial cells, the enterocytes in the ileum, colon, cholangiocytes, so it can affect, there are various liver findings that are seen, myocardial cells, kidney and bladder. So there's an immense amount of areas in the body where this virus can attack. Recognizing that some of the suspected cases may have been as early as November, but December is where it really got reported, and from there it spread. Our first case in India happened on the 30th of Jan 2020. And this is where we stand today, about 45 lakh cases around the world and about 3 lakh deaths around the world, more than 190 or 200 countries involved, and it's progressively spread. If we were to get a perspective of where we stand compared to the US, which today has the largest number of cases, we are at about 86,000 cases. US is at about 1,443,000 cases. We've had a small number of deaths compared to the US, 2,753. Still, the death rate is about 3.2%, which is an average. Death rate in the US is about 6%. Remember that Italy and Spain at the peak of their outbreaks were somewhere between 9 to 12% in the death rates. The number recovered is about 35% in India. You can see the numbers in the US. The number of tests done, while we've done about 21 million tests, the positivity rate in India is about 3.6%, whereas with 10 million tests in the US, it's at about 14.7%. And as we can see with the confirmed cases, the daily rise and the log scale, we are nowhere in terms of flattening or stopping or slowing down. It's still an uptrend that is seen in the confirmed cases. And so clearly in India here, we have to be very careful. The lockdown has helped immensely in slowing the rate. You can see the numbers compared to other places which have 1/3 the population of India, the US, for example. But clearly there is a problem. And when we look at how this disease presents, as I mentioned, the data initially that had come out had said about 40 to 45% patients may be asymptomatic or pre-symptomatic or very mildly symptomatic, where a little sore throat or a little loss of smell may not even be recognized as a COVID-19 infection. And what has been found in India is up to 69%. That's a very high number. 69% of patients might be asymptomatic or very mildly symptomatic. The remainder of the patients will have some upper respiratory manifestations, as I said, loss of smell, loss of taste, fever. Fever is not 100% presentation. There have been, even in Wuhan, where this all began in China, it was found that at the time of admission, 70% patients had fever, 30% did not have fever. Later on, during hospitalization, almost all of them became febrile, but the cough and the shortness of breath can come before the fever comes. Then comes the body pain, the myalgia. There can be gastrointestinal manifestations like diarrhea, nausea, abdominal pain, even to the point of ulcerations in the stomach or intestines, and even perforations have been described in advanced stages due to many different reasons. Hepatobiliary manifestations such as elevated SGOT, SGPT, even cholangitis, cholangiopathies, obstructions that have been seen. So a lot of GI manifestations, but only GI manifestations, fortunately, a few, less than about 4-5%. Other symptoms, ocular symptoms, and interestingly, eyes have the ability to take the virus in. So the ability, the infectivity through the conjunctiva is very, very high for this virus. And ocular symptoms like conjunctivitis and other ocular manifestations can be part of the presentation. Cardiovascular symptoms, chest pain, almost presenting like sometimes a myocardial infarction or other cardiac manifestations with elevated troponin levels, elevated D dimers, elevated CPK MBs. Many things can be seen, so high level of suspicion. And then a very tricky one, which would be the cutaneous manifestations. So the skin presentations, and those have really been tricky. As you can see here, a lot of transmission occurs before the symptoms. In Bangkok, there were even cases very early described where a skin rash, petechiae, low platelet count made them think about dengue, but it ultimately turned out to be COVID-19. So with the upcoming rainy season, where we typically see rise in dengue cases here in India, we will have to be careful about this presentation. And other skin manifestations like rashes, urticaria, chickenpox-like vesicles. I'm sure you all have heard about the little kids presenting with Kawasaki disease-like presentation. Itching sometimes present, but fortunately the skin manifestations, even if maybe moderate to severe, don't correlate with disease severity. And one feature that we have really learned down the line is the ability to cause small vessel occlusion, microangiopathic, microthrombotic lesions, which affect the lungs, the heart, These have been known to affect the skin also, and hence they can give petechial and bruise-like lesions on the skin. And you all have probably in your messages in different groups seen things like COVID toes and other things being mentioned, which are due to this small blood vessel occlusion or microangiopathic lesions that are being seen due to vasoocclusion, which is a feature that we have realized. Now, add to this sometimes the drug reaction that may be used. So when we look at asymptomatic transmission, this was a very interesting paper published very early in New England Journal of Medicine, where a person from China flew, visited Germany for a business meeting, they attended business meetings, and different patients at different points of time got exposed to them in the meetings and had symptoms developing anywhere between 5 to 7 days later. And when the person who had flown in from China had come for the meetings, he was completely asymptomatic. He did not have any fever, cough, sore throat, nothing. And so that makes it really tricky that these transmissions can occur before a person has any symptoms to know that they are infected. And interestingly, the viral load in asymptomatic people can be just as high as symptomatic patients, which makes it even more complicated. And this was a paper that you can see in New England Journal of Medicine in February, 19th of Feb in NEJM, which showed that the viral load that was detected in asymptomatic patients was similar to the symptomatic patients, which increases the chance of transmission. And hence, the likelihood of community transmission is very, very high. We know that this is transmitted through coughing and sneezing, but it can also be transmitted through microaerosols generated during talking, shouting, singing. We've heard cases happening in churches where programs were going on, or other common gatherings, as we know in Delhi had happened. Contact transmission from fomites and surfaces, and then direct contact, certainly. And then feto-maternal or transplacental transmission, which remains a concern but still is a query. Here you can see that as the virus enters through the ACE2 receptor, comes in viral replication, viral maturation of the viral proteins, and the release of the viruses, our body, our immune system has an option where between the feedback between macrophages, which are part of our innate immune system, along with NK cells and dendritic cells, and then the monocytes and the T cells, we have an option of either mounting a healthy immune response where the infected cells are quickly cleared, the virus multiplication and intraepithelial transmission is stopped, neutralizing antibodies are developed, and then there's minimal inflammation, or a dysfunctional immune response can be created. And this is a very important part of the immune system and the reaction of the immune system, because when the initial innate immunity attacks this virus and starts clearing it, and many a times successfully does it, the patient starts feeling better. And there have been many, many cases where a patient has felt that they are improving around day 8, 9, 10, 11 of the disease, and then suddenly they get worse. And that sudden worsening is what the dysfunctional immune response is. And in that dysfunctional immune response, there can be excessive infiltration of macrophages, monocytes, and T cells. There can also be systemic cytokine storm that we know, like presenting like an ARDS, an acute respiratory syndrome kind of a ARDS picture. There can be pulmonary edema and pneumonia that can worsen. And then obviously there can be widespread inflammation and multi-organ damage. And this is the reason why understanding the immune response to COVID-19 SARS-CoV-2 virus is so important, because now data is suggesting that where people were trying to reduce the inflammation later on, once the person started getting worse, once they had that biphasic after improving worsening, steroids were used, anti-inflammatory use, everything was used. It may make sense that when the person is clearing the virus effectively by their innate immune system, that using steroids earlier on in the disease may actually prevent the second wave of causing this infection. And this is really something that practitioners need to realize the importance of, and there is certainly research going on this. I cannot say that this is the way to go, but in cases that have presented with pulmonary changes on X-ray and CT scan and are showing changes, it may be worthwhile to consider, even if the patient is not severely ill, they're just having some oxygen dependencies, they're moderate cases, it may be worthwhile considering anti-inflammatories at that time. Also, very interestingly, just within the last few weeks, the first paper looking at the cellular responses. So everything that has been done so far has been looking at IgG, IgM, IgA production. People haven't been looking at the cellular immune response, and the cellular response, what is called from T cells, the helper T cells, CD4, and the killer T cells, the attacking cytotoxic CD8 cells, is very important also in COVID-19. As we know, it's true in all viral infections. Cellular immunity is a very important part. And finally, research has shown that in patients who have recovered from a COVID-19 infection, CD4 specific to SARS-CoV-2 is present in 100% patients, and CD8 is present in 70% patients. Now, interestingly, patients who have never been exposed to SARS-CoV-2, who have not been infected, when their blood was examined for cellular responses to SARS-CoV-2, interestingly, 50% had CD4 that could recognize SARS-CoV-2, and 20% had CD8 that could recognize SARS-CoV-2. This is also very important because when vaccination strategies are being determined, I'll talk about it a little later, we have to realize that the cellular immune response, which ultimately directs and guides the humoral immune response, which produces IgG and IgA, is just as important. And our exposure to the old coronaviruses, which are still circulating in our community, may be due to certain shared epitopes in spike proteins, in nucleocapsid proteins, give us some protection from the virus. And that may be one of the reasons why some people tend to respond so much better to this virus and be even mildly symptomatic, which is 80% of the patients, or be asymptomatic, which can be up to 60, 70, 50% of the patients, and get away because there may be some prior immunity that we have. So what have been told so far to stop the spread of germs? We've been told social distancing, very important, avoid gatherings. The lockdown has helped flatten the curve, slow down the rate, so our healthcare system can respond. Self-quarantining when someone is exposed and they're in that waiting period, whether they might be in incubation, might develop. Geographic quarantining, where we have the yellow zone, the orange zone, or the green zone, the orange zone, and then the red zones. That's called geographic quarantining, where places are in stricter control. Case isolation, contact tracing, very important, slowing the epidemic and ultimately mitigating it. When we look at local transmission, I don't need to really go into this. Most of you all know what these things are. Eventually, we have to get our practices ready for facing the COVID-19, and I will talk about this in a little later and through the questions. But right from what we do, because recognizing that asymptomatic transmission is so common, and any of these things that you may require later, you can get in touch with me or get in touch with the Sun Solaris team, and we'll share these with you. But right from before the patient arrives and doing some phone triage and screening to when they arrive, the protection for your staff, protection for the patients, reducing the number of family members that come with the patient, staggering the appointment so there's no crowding in the outpatient department, to using the proper outpatient preventive equipment is all very important, because asymptomatic transmission is really our biggest concern at this point of time. And a lot of education, first of yourself, which you all are doing through such webinars and programs, second of your staff, and third of the patients and their families is so important. When we have a case, the lab testing obviously is very important, and so far the RT-PCR through the nasopharyngeal and oropharyngeal or throat swabs are the gold criteria. And these are done in all symptomatic individuals who may have, we used to say international travel, but frankly, now I would even say travel to the red zones within India. So if someone has been in a hot spot, what is being called in the media, then they are symptomatic, they absolutely need to be tested. All symptomatic contacts of lab confirmed cases, all symptomatic healthcare workers, we realize that they are at increased risk. All hospitalized patients with a severe acute respiratory illness or an lower respiratory infection, that is an influenza-like illness, that's what ILI stands for. And then asymptomatic direct and high risk contacts of confirmed cases who should be tested around day 5, and if necessary after the quarantining period at day 14. And this can be done obviously in their homes if the ability and the circumstances allow. When to do which test? Early on, it's RT-PCR. After day 7, we can start thinking about the immunoglobulin, IgG and IgM tests, because they start getting formed from day 3 to 7 and they peak around. So when we look at the best test that is available right now, which is a test called Alexis from Roche Pharma, not available in India yet, it's there in the US. It will eventually get here, which has a 99% specificity and 100% sensitivity. They recommend that kind of sensitivity and specificity at day 14 of the infection, not at day 4 or 5. So immunoglobulin tests will really help us in the later phases to know who's been infected, who's possibly become immune, because these are not necessarily neutralizing antibodies. So we can't say that if the antibody test is positive, the person is safe. But certainly they have been exposed and they have come out of it. So we know that there has been some asymptomatic, pre-symptomatic or mild infection. There are a variety of tests, and we certainly have these that are being used by our Indian government and all over the country, both in government and private settings. There were many antibody tests that came out very rapidly, and some of them initially got validated, but later on were found to be unsatisfactory. And I'm sure you all have all heard about the tests being sent back to China because they were not working well. Well, the good news is very recently ICMR and NIV Pune have come up with something called the COVID Kavach ELISA, which along with Zydus Cadila is going to be available in India for testing. The process is on. And as I mentioned, Alexis is one of the best products that is available worldwide. But again, these are going to help us know who's already been exposed, who has been. So, people talk about an immunity passport. I don't know how far as an immunologist I can say that's true, because you cannot really say with a positive antibody titer that someone is safe. But certainly we know they've been exposed. Initially, the test had a problem because we didn't know whether we were picking up the old coronaviruses or we picking up SARS-CoV-2. The newer tests are very, very sensitive and specific. So I think that will help us in more population screening. The ICMR guidelines for influenza-like illness, I think these are all available, and I would strongly suggest that you look at the websites of the Ministry of Health and Family Welfare. The numbers will come a little later. But these being positive, the antibody test may be able to screen if the screening is, if the suspicion is high and the antibody test is negative, then RT-PCR has to be done as a confirmation test. Anyways, that is the gold standard. I shall repeat that again. These are the numbers very much available, and the ICMR and the Ministry of Health and Family Welfare updates do come on the websites, and I would strongly suggest all healthcare practitioners to keep track of it. Now let's come to the therapies that have been used. There was a thought that we could use chloroquine and hydroxychloroquine. I'm sure that there may have been some of you all who took it as a chemoprophylaxis. That has really fallen by the wayside because the studies that are now coming out seems like, at least in infection, it doesn't help prophylaxis either. But the guidelines are the guidelines here in India, and I would suggest you do what you feel best, but they work on the membrane fusion part. There are some other drugs that work on the spike protein. Certainly, we have heard about the antiretroviral drugs and the antiviral drugs, which have not been, again, very successful, but in combination, in concoctions, might have some benefit. And then we know about the IL-6 receptor binding, which is done through the tocilizumab and serelumab. And with that, there is some benefit, but these are again reserved for the severe cases. These are not for the mild to moderate cases in any way. Certainly with the remdesivir that has come out more recently, remdesivir has been shown to have some benefit in reducing the duration of hospital stay. We don't have very clear data whether it actually reduces fatality or mortality from the disease, but we know that it can reduce the impact from the duration of hospitalization in some severe cases. When we look at the timing of the drugs that are given and when they are given, phase 1, phase 2, phase 3, phase 4 trials that are being done for antivirals, anti-malarials, immune boosters, as you can see, given very early in the disease, anti-inflammatories, as I have mentioned, anticoagulants, certainly heparin and other similar biosimilar products, stuff that works in those different phases are very important. Vasodilators are being looked at the late stage of the disease. Anti-angiogenic bronchodilators, antiparasitics, as you know, people have tried with ivermectin. The results are again not in, and again not very strong. Antioxidants and mucolytics. So there are tons and tons of trials going on in different phases, and these are the different molecules that we believe that there will be some results by the end of June coming out for some of these molecules and how they have been working. But again, as I would say to all of you practitioners, right now it's all about prevention. It's all about slowing the spread. It's all about symptomatic management. And that should really be the goal. And at the right time, referring the patient either to the COVID care center or to the COVID hospitals with the right kind of evaluation that can be done there. And while in outpatient evaluations are being done, are simple CBC with CRP and also a serum ferritin, SGOT, SGPT. These can be non-specific markers that give us very good idea about what the problem is going on. Again, a chest X-ray, ideally you would want to do a HRCT chest, but that's not really something that I would routinely recommend. But when findings are there, getting these patients to the right place for the right care can be very important. I get asked as an immunologist about the vaccines and the trials for the vaccines. Now, what you have to realize is the vaccines are of many different types. If the vaccine actually works with the spike protein or works with the way the viral proteins are impacted upon by different immune cells, cytotoxic lymphocytes and other cells, or working on pathogen specific antigen presenting cells. There are different mechanisms, but they are all in phase 1. I do get asked about the studies going on with what they call the Indian vaccine. You have to realize that's not really a vaccine specific to COVID-19. There are vaccines specific to COVID-19 also, which research is going on in India with NIV, with ICMR and other locations. But the one that they are talking about being available as early as July, August, that is more of a non-specific immune stimulant that has been used in gram-negative sepsis, and the possibility of that boosting the immunity and helping in COVID-19 infections is something that is potentially being looked at. But again, I feel that as an immunologist, if you ask me, there has never been a vaccine that has developed in less than 4 years. So even if we did 1 year from now, we would be doing really good, because there are many arms of the vaccine trials that are potentially being skipped, or you can say fast forwarded in an attempt to get this done. These are the vaccines in development. If you take the lower image, there are almost 80 different vaccine candidates that are in different stages. As you can see, phase 1, it's about 6 or 7, in preclinical, exploratory, and then exploratory confirmed. So there will be animal trials, then there'll be human safety trials, then there'll be human dosing trials, then there will be actual phase 2, phase 3 trials, and then the vaccines can come out possibly in an expedited stage. But we should not be sitting and banking on vaccines as the final answer, because our final answer really is about taking care of ourselves. And I'll come to that in the end of the presentation. So some points to be careful with: aerosol generating procedures should not be done in clinics. So for example, I'm an asthma specialist. I have to do a lot of lung function tests, spirometries. I'm not doing those in my clinic right now. I recently got this idea from a friend where the patient could be outside and we could be inside the clinic, and through a window that has been shuttered down, we try to do a spirometry. People are trying all kinds of things. But at this point of time, asthma would be a clinical diagnosis. We can't do exhale nitric oxide tests. All of these are aerosol generating procedures, or our staff would have to be in full PPE to do that, and so would the rest of the clinic people in it. because it can transmit through different rooms. MDIs are preferred to nebulizations. We are avoiding throat examinations because they can cause gagging and coughing, but we may still have to do it with the right precautions where needed. Telemedicine is really the safest thing right now, and that's what many of you all are doing and will do in the near future with all the guidelines that are there, again, from the Ministry of Health, from our medical councils, and from other organizations. But certainly we have to take care and we have to use. So the people ask me what are the minimum things. So the minimum thing is a surgical mask, ideally an N95 mask for healthcare professionals, using gloves, preferably nitrile over latex, because nitrile you can even sanitize if needed in between. Latex don't sanitize very well, especially if they are powdered latex gloves. You can also or should use goggles or a face shield, because that does cut down some transmission. So even if you're doing a simple outpatient practice, this is the minimum that is recommended for physicians to use. Heat and humidity has not seemed to affect the transmission really. Otherwise, places like Singapore and India, which have been pretty hot, would have had less cases. But as you can see, the number of cases are increasing. And this has actually been studied, because in a public bath where the average temperature was 40 to 41, they found that there was still transmission of cases happening. So heat and humidity is really not the answer. Face masks, even the US CDC, after saying initially everyone doesn't need it, now says everyone needs it. I'm a strong believer everyone needs it. Even if you're using a 2-ply cloth mask that you stitched at home with a good quality cotton that has been pre-shrunk, so after you make it, it doesn't become smaller on your face, and is kept clean, washed regularly. For public, for us, as I said, N95 masks or what is called FFP2 mask, or using a 3-ply surgical face mask is very, very important. I don't really bother about different things that different people say. I have been saying, I've been doing interviews on television since the 21st of Jan is when I did my first interview. Even then, when lockdowns had not happened, I was telling people, when you're traveling in the train, use your dupatta if you're a woman, use your rumal, your handkerchief, cover, because that's the least you can do. And places like South Korea and Japan have shown us that using face masks sincerely do make a difference. So do not underestimate that for whatever it is worth. And then face shield, because we know the ice can be a powerful source of transmission. As I mentioned in the outpatient treatment, people ask about hydroxychloroquine. There have been several studies now internationally done which are not showing that great of results. Azithromycin was asked about, again, not beneficial in several trials. If you do have bacterial superinfection over the viral infection and you think you need an antibiotic, then azithromycin may be a good choice at that point of time. Overall, what I would say for all of us, don't panic, stay sane, stay informed. Remember, this too shall pass. 80% patients, mild infection. Another 10 to 14% patients, even if they have moderate disease, will get out alive. It's the last 3 to 4% who really are having fatalities. And they are the ones that the healthcare services has to be most focused on in providing, but we can't ignore the mild to moderate cases. So that brings me to what probably all of you all have the maximum interest in, and that's immunity boosting. Starts with simple thing, hawa hi dawa hai, or Suraj ki roshni, sunlight, is one of the most powerful immunity boosters. Besides, it also gets us some vitamin D, which, by the way, low vitamin D, in some studies that have been done worldwide in retrospect, have shown that low vitamin D is correlated with more severe COVID-19 infection, and having good levels of vitamin D, hence, as a counter answer, might even be protective and make the disease mild. So optimizing it, I don't believe in over treatment. Fresh, healthy diet, eating 3 fresh meals, drinking warm water. I'm sure you've heard about it. Don't go crazy with it the way some of the things are on the internet, but avoid cold foods. Exercise. The lockdown is not a time to sleep more and sleep longer and laze around, but exercise, because when lockdowns open is when again the transmission will increase, whether you call it community transmission or whatever label you want to give it. I believe community transmission is going on. I believe some people say it is not because we are not testing enough, but that's semantics. You know, the World Health Organization took almost 20 days before calling COVID-19 from an epidemic to a pandemic. I knew it was going that way. And so community transmission is there. We are not testing, so we can't label it that way. So exercise and boost your baseline immunity so that you don't have a problem if you do get exposed to the virus, which eventually in the next year or two, we all are potentially going to get exposed to it. Restful sleep, 6 to 8 hours, very important for our immune system. Yoga and pranayama, if you believe in those things, I do. In ancient India, ancient systems, I have a great faith and belief. Do it. It helps you. Supplements like vitamin D, optimization of the level. Don't go overboard and overdose. Zinc, because there is hypervitaminosis D that also occurs. Zinc and vitamin C have been known for common colds, rhinoviruses, viral infections, influenza for a long, long time. Again, don't go crazy and overboard, but they may have some benefit if a person doesn't have a very healthy and what I would call varied diet. A positive attitude and mindset. I have released a video called Corona Anxiety. Y'all can go on YouTube and see it. Y'all can subscribe to my YouTube channel. It is very interesting. I put out different videos out there. But read about it. A lot of mental and psychological issues going down because of lockdown, because of anxiety, uncertainty, fear, financial pressures, whether it's domestic violence, whether it is panic anxiety, whether it is depression. There's a lot going on, and you really have to take care of your mind at this point of time. Meditation, strongly believe in it, do it. There are many, many ways to do it. If you can, it's wonderful, because the calmer your mind, the calmer and more what I would call resolved and peaceful is your immune system. Let's not forget our Ayush brethren. They have put out a lot of things out there in Ayurveda, in homeopathy, in Unani. Um, Take it for what you believe in and what your patients believe in. Tulsi, neem, turmeric never hurt anyone. I know that they don't, because we eat them and we consume them all the time. We know that things like honey and warm water can't hurt you if you do it in reasonable ways. Such is the power of this country called India. And I would strongly suggest to people that you all really need to look at these things. Large number of people have been given homeopathy therapies, and people who believe in it swear by it that it's helping them prevent the infection. Healthcare professionals are being offered it even from mainstream medicine. I'm not saying you should go out and everyone take it. I leave it up to your independent decision. But remember that these uh, lines of treatment have lived what I would call the test of time, because there is some value to it. And by boosting our immunity, we can certainly do a lot to take care of ourselves. These are some of my contact details if you'll need to get in touch with me. I will now start taking questions. I believe they have started coming in through the YouTube channel, through a Telegram group that I have called Dr. Roy Health Solutions or Dr. Roy Allergy Times, which is meant for doctors. Our contact addresses are there. I'm located in Bandra in Mumbai. And certainly you all can get in touch with me for further details. I can't cover everything. There is a lot about the type of consent forms you should have when you start seeing patients again, what you should do for each patient. We are putting out something called standard operating procedures, SOPs. Stay on the lookout. Contact us if you want them. I am in the process of finalizing them for what to do in your outpatient practice, what to do your nursing home or your clinic, what to do in the inpatient and hospital, what to do in the operating rooms. So those are coming out, and guidances are there, as I said, from the Ministry of Health and Family Welfare, the CDC. Do look at those. And with that, I shall come back to taking questions. So let's see, in the questions that we have, we are looking at, okay, the first question is talking about the role of herd immunity. Herd immunity is, I'll give you some background on this. So herd immunity is based on something called R naught. R naught means one person who has a confirmed COVID-19 infection, symptomatic or asymptomatic, whatever, how many people will he transmit that to? In India, when the disease was at its peak and spreading, the number was around 3 to 4. Now the latest data suggests it may be at around 1.5. Places where there's been success like Japan, South Korea, the number is below 1. When it's below 1, it's not going easily from person to person. It's going to less than 1% from an infected person. That means they're doing a great job in prevention. Now, with an R naught of 2, okay, just 2, which means one person giving it to 2, we need 60% of the Indian population, which would be, as you can expect, around 75 crore people to have been exposed and developed immunity, cellular, humoral. Right now, people are able to check only humoral immunity, so IgG, IgM, and hope that that immunity is of the neutralizing type. So if it is of the neutralizing type, then we would be expecting that those people will be protected from infection. If those 60 to 70% of the population are protected from infection, then they will prevent transmission to other people because the R naught will be below 0. Problem, I'll tell you. Let's take Wuhan, okay, where there were the largest number of cases in the shortest amount of time, reached up to 60, 70,000 in a very short time. There are 11 million people who live in the Hubei province and in the surrounding areas of Wuhan. And if we look at the number of cases compared to the population, it was believed that 0.45% of the population, 0.45% of the population had an infection. Okay, so we expect that these people should have protective antibodies. So then the people in the Hubei province and Wuhan area started doing random testing of patients for IgG and IgM, hoping that if there would have been asymptomatic transmission, a lot more people would have had protection. Guess what? The number of people who had IgG and IgM was 2.5% of the population. Okay, the epicenter of the world where the epidemic all began, after all that they did, lockdowns, strict control, cluster caretaking, everything, 2.5% of their population is currently on estimate. So how many tests they've done total and how many actually showing antibodies. So reaching a level of 60 to 70% seems like a optimistic dream right now. Don't take me negatively. I'm not a negative person. I'm very optimistic and hopeful. But if we are hoping that herd immunity is going to protect us, it's going to take time. It doesn't happen in 1 or 2 days. It takes years for herd immunity to develop. And so potentially, if a real successful vaccine with a successful target, with a successful track record comes in, has a better chance of developing herd immunity. So that's about herd immunity. The next question comes from the dose of zinc. Dose of zinc from Dr. Akhil Contractor. Dr. Contractor, zinc, the daily requirement is only 20 milligrams per day, max 40. Some of the preparations that are available in market have 100, 200 milligrams of zinc. That's a lot of zinc. And you don't want to overdose on zinc. You're not going to cause any major harm, but still, if you're able to get somewhere between 20 to 50 milligrams of zinc into the body, that's adequate. There are natural sources for it. Do read it up. And I'm a big believer in eating the right foods, having nuts, having seeds, having different things that can give you it, rather than taking pills and popping pills. But that's really a choice that you have to take as a clinician and your patient and their family. What is the optimum time for starting IL-6 inhibitors and for how long do you give it? IL-6 inhibitors actually require just a dosing for 5 days, potentially for 10 days, but most cases require only 5 days of dosing. The time to start it is when a patient is progressing in their respiratory distress. So where they were requiring only oxygen, they start requiring high flow, BiPAP, requiring more aggressive intervention, and they start showing the signs of what we would call a cytokine storm. So that's really the type of cases. So these are hospitalized patients. These are never going to be used. As it is, getting the drug is very hard. Getting it on a compassionate basis, getting it because the cost is prohibitively high. So you really want to use it in the ICU patients who are potentially showing the features of what we could call an early cytokine storm. And sometimes even a little before it, there are certain lab parameters, immune parameters that you can track and use it at that time. Similarly, if you're using remdesivir also, the dosing has been shown for a short period is enough. 5 days is enough. Sometimes the studies have been done for 10 days. But again, like I said, that's in severe cases or moderate cases that are becoming severe. How much time does RT-PCR take? Question from Dr. B.S. Patil. RT-PCR turnaround officially should be 1 to 2 days. But I have heard in India that there have been people who waited up to a week to get a result. Okay, I think it has to do with the efficiency. It is not an easy test. The viral particles have to be replicated. The RNA has to be replicated, run through different types of real-time comparative testing, amplification processes of the RNA before you can get the results. So best case scenario, 2 days, 1 to 2 days. Worst case scenario, few days. Antibody tests will happen within hours, so within a day turnaround. But again, they're not good at diagnosis. They're good at knowing who's been exposed, who's gotten infected, who has been in the past infected, or has been exposed and is having a mild infection. Those can be helped again only after day 10 or 14, not early on the antibodies. What is the role of AC inhibitors? Receptors in COVID-19, as I said, they are the source of where the virus enters the body. ACE inhibitors are its main entry point. ACE inhibitor drugs and ARBs do not have to be stopped. In fact, some early studies are even suggesting that being on them may help, but I'm not saying people are to be started on it. If they are on it, just don't stop them, because you're not going to cause a problem. The next question comes from Dr. Rajesh Gajara. He asks, once a person recovers from COVID-19, does it mean that he's immune to reinfection? A very, very good question. It's $1 million question right now. I will answer it in terms of SARS, which came in 2002, 2003, and in terms of MERS, which came in 2011-12. We have data for that. So what was found was people who got SARS and recovered up to 3 months, they had good titers of neutralizing antibodies. After 2 months, 3 months, 4 months, their antibody titers started going down. Up to 1 year after the infection, they had still detectable antibody titers, but nobody knew if they got re-exposed to the virus, whether that titer would be adequate to protect them or not. So that brings us to the point that just as we have had influenza, so the first recorded pandemic of influenza was in 1580, okay? 10 lakh plus, probably close to 1 crore people must have died in that pandemic of influenza, estimated. But influenza has continued to survive, whether in the form of human influenza or in the form of swine flu, bird flu, whatever else. Flu never left us. So some people, and I am one of those, believe that SARS-CoV-2 is here to stay. It may never completely go away. So it may happen that we may get exposed to it, get the infection, develop immunity. After some time, when the immunity wanes, we might get again potentially at risk for getting the infection, but because we've seen it before, we'll be protected. And hence the role of vaccination becomes important. But I'll again tell you, every single vaccine that comes into the market, don't just jump on it thinking that vaccines are the answer, because the data and the study has to be really strong. And I'm definitely not a person as an immunologist who just jumps and says, okay, this vaccine is great, use it. I would say that use it with caution, use it with care, study the data, understand how it works. We know influenza vaccination works 70%, but 70% is better than 20%. So it's worth using and it's worth recommending and taking. So certainly things that we have to look forward to. And even the old coronaviruses that were studied. So as I told you, the OC43, the HKU1, those coronaviruses, because they cause common cold, sneezing, runny nose, little fever, little body pain in people. And we look at the immunity to that. That immunity also tends to wane in a year or two, and then the person can catch it again. And depending on how immune compromised or how weak the person's immunity is, because they don't take care of themselves, they don't exercise, they don't eat right, they don't sleep right, they eat junk food, they take a lot of stress, they just damage their immune system, they may get prone to it even faster. And I think the same will hold true for SARS-CoV-2 also. So the next thing that has been asked here is what is the percent of false positives in RT-PCR? So RT-PCR has a sensitivity of 70%, which means 30% can be falsely negative. The possibility of false positive in RT-PCR is very, very low. So RT-PCR is a very, very specific test. So false positivity rates are very low, very, very low. We are talking in a few percent. The sensitivity is not that great because you can miss an infection. And in fact, there are some very interesting data coming out now that the level of level of viral shedding in saliva is even higher than it is in respiratory secretions. So potentially in the future, and you all can stay tuned for this, there may be tests where salivary samples will be used to detect COVID-19 infection. It's still some ways away. Don't jump on this because Dr. Roy said so and go searching for. But shedding in saliva, just as you may have heard shedding in stools, even after the person has recovered from the infection, shedding in stools can go on for up to 30, 40 days, which is why using hygiene, respiratory hygiene, using bathroom, toilet hygiene, using following our Swachh Bharat Abhiyan and our Shauchalaya is being closed, cleaned, especially if in your clinics and all you have them, sanitizing them with what I would call a 1%, 2% hypochlorite solution, bleach solution, and cleaning all the surfaces also in the clinic is so important. Next question that comes up is, sir, 3-ply mask can be reused? If so, when? And mask should be washed with plain water or soaps. 3-ply mask cannot be reused. Use 6 hours of use, you have to throw it away. There is no way of reusing 3-ply mask. If it is a cloth-based mask that has been made, there are some masks that look like 3-ply masks, but they're cloth-based masks and they can be washed and reused a couple of times. But those are not what healthcare professionals should be using. Those are for general public. The N95 masks you can do rotation with. So you get the mask, you use one mask on one day, keep it in a brown paper bag. Second day, use a second mask, keep it in a brown paper bag. Third day, fourth day. On the 5th day, you come back to the first mask because in 72 hours, most COVID-19, most SARS-CoV-2 will have died on any surface. So you can reuse it. You can do it for a certain number of times. So there are masks that can be cleaned and reused. The next question again from Dr. Rajesh Gajara, steroids can help if started in asymptomatic cases, low dose. If you're asymptomatic, you don't have symptoms. You're not supposed to take steroids, please. Should mildly symptomatic people use steroids? Again, the answer is no. Steroids, you would start thinking when someone is moderately ill, which means they're requiring oxygen, you're having them in a COVID care center, health facility, and you don't want them progressing to being serious or critically ill. That is when I would think of using steroids. Don't quote me. This is not any guideline. This is as an immunologist, and I've been tracking COVID-19 and SARS-CoV-2 from day one. This is my personal opinion on the available data. People will say that this is not the standard of care, and I agree with them, but this is just based on whatever literature is out there right now. But definitely not an asymptomatic people. Steroids are not for asymptomatic. For asymptomatic people, it's like normal population. What do? You don't know you have it. Those are the people that can drink warm water, can have haldi and honey, and can have all the other, can have the Ayush formulas, can do the exercise, the gym. Because they are asymptomatic, their immune system is likely fighting it off very successfully. Don't do anything for them, please. If you have a family, one person is diagnosed, others are asymptomatic, don't start giving them steroids. That's not right. Is there any objective way to judge someone's immunity, whether adequate or not adequate? So as an immunologist, I do when patients come to me and I take their history, I take a very careful history. I spend half an hour with patients. If I find that someone's immunity is not right, there are certain, besides doing a simple CBC and checking for certain vaccine titers, there are other ways. So as an immunologist, we do specific what I call immunity screening tests. But I don't think that in general population, other than doing a CBC and looking at the neutrophil count, the lymphocyte count, eosinophils for allergies or parasitic infections, monocytes and viral infections. And as you know, in even COVID-19 infections, having a reversed neutrophil to lymphocyte ratio greater than 3.5 is very helpful in knowing that someone has the infection. There isn't a whole lot that can be done. But as specialists, there are certain tests that we do, which are subset analysis of lymphocytes and looking at antibody responses to certain vaccinations in a certain way. There are ways to know whether a person's humoral immunity, cellular immunity, everything is working right. And I do that in my practice, certainly for patients who are keen on it. It is said that the pore size of N95 is more than COVID virus size. Is it true? If yes, then how can N95 be useful? Problem is there are what I would call non-N95 masks being sold as N95, unfortunately, in this country, because every, excuse the language, Tom, Dick, and Harry has started making them and selling them. And I don't think that they are properly tested, properly looked at. A normal N95 mask does have the ability to prevent particulate matter. Nobody said that it can prevent COVID-19 virus. We are preventing respiratory droplets. We are not preventing viral transmission. Okay. You have, I'm sure, heard of doctors who have used full PPE and still gotten infected. So the virus is a whole different story. We are talking respiratory droplet, micro droplet prevention. The N95 pore size is enough to do that. Now, a good N95, a standardized N95, a proper N95, shouldn't have those filters and respirators for easy breathing, because then your exhalation carries stuff outside. Not a good idea to do that. If you are really concerned, okay, I'm giving you a tip, an idea. There are people who, after using an N95 mask, also use a 3-ply surgical mask on top of the N95 mask. So you can seriously consider doing stuff like that if you're, I won't call you paranoid because I don't know your practice, and you may actually be exposed to a lot of people, and they are potentially, everyone can be COVID these days. So if you want an extra level of protection, a 3-ply on an N95, and the 3-ply gets discarded, the N95 gets reused, as I said, every 5th day. Hydroxychloroquine 200 milligram, can it be used for prophylaxis? So while ICMR has recommended it, I don't know of too many other places in the world where it's being used for prophylaxis. And I'll tell you why. 2 reasons. One, are rheumatology patients who are on hydroxychloroquine daily. So, you know, it's not even that once a week kind of, or once in 15-day dosing. They're daily on it. They have still acquired COVID-19 infection. So clearly it doesn't do a very great job in preventing infection. Second, whatever data is available right now doesn't seem to be that great in helping. I'm not completely disreputing or disregarding that process. Do it for your own concerns. Remember that there are some cardiac side effects. Remember that with long-term use, there are some ocular side effects. Okay. So use it very carefully is all I can say, but the data is not that strong. Data is not that strong. Dr. Sujata Mehta asks, what is the right time to start IL-6 antagonists? I already answered that before. Those are reserved for people going into a cytokine storm kind of a situation. There may be some cases that in a severe case in the ICU on ventilator, doctors might consider using it for its antiviral effect and properties. Certainly can be used. Definitely not for moderate patients who are just on oxygen in the hospital, being monitored, given supportive care. Those are not the kind of patients you're going to use IL-6 for. So I think that we have taken most of the questions that have come in. Again, if there are no further questions, I would like to thank Sun Solares and the entire team who are working behind the scenes to make this possible to come to you. I thank my team, which has worked behind the scenes in helping me get to this stage and do this with you. And some of them are watching. And thanks to all of you all who have kindly tuned in and have very patiently heard what we have to say. I am, if any of y'all are interested, doing a very interesting talk with a very large group of dentists, 90,000 dentists around the world. It's called World Dental Association. It's going to be a Facebook Live on my Facebook page also. It's called Dr. Roy Asthma Allergy. That's the Facebook page if you're searching for it. And if you go through the handle, Facebook handle, it's at Dr. Roy Health Solutions. That's the Facebook handle. It'll be live on that, and it'll be live on World Dental Association, because dentists, as you can expect, are really exposed to microaerosols, and they're right there in the face. And I just told you saliva is a great way to transmit the virus. So we're going to be doing a question and answer session with them. You all are welcome to tune in and hear it. And once again, thank you very much. Have a good evening. Take care. Stay safe. Keep your immunity boosted. I do a lot of other things in ancient medicine. If any of y'all are interested, get in touch with me. I believe in ancient medicine, and I do a lot for my patients. My patients have had nothing to worry about in this whole time, because I have prepared them for viral infections that are helping them even now with SARS-CoV-2. It's not the virus that's the problem. It's our immunity that needs to be optimized and best. So take care, be immune, stay safe. Thank you very much. God bless us all. Take care.
Thank you, Dr. Roy, for the informative lecture of today's time. And thank you all participants on behalf of Solaris Sun Pharma Division. I thank you all the participants as well as especially Dr. Roy. Thank you so much.
Thank you.